Ladies and gentlemen, we're going to do a deep dive now into our second panel discussion of the day. Please do take your seat. We're going to be looking at decoding Clinico Genomics from population scale to precision therapies. And we've got some experts and global speakers here joining us to give us that insight and wisdom that we've promised to you here at M42. Please may you join me in giving them a very warm welcome to the stage. And if I can ask them all to come and sit underneath their names. Dr. Val Zavirev, who is the laboratory director at M42, please do give him a big round of applause. Dr. Farwad Khan, who's a chair of oncology, Cleveland Clinic, Abu Dhabi, at the Hereditary High Risk Program. Dr. Stephen Grogmeyer, the Chair of Oncology at Cleveland Clinic, Abu Dhabi. And I'll be handing over my mic to the brilliant moderator I'm going to be handing over to, Albara El-Khani, who's a Senior Director of Operations at M42. Thank you very much.
Thank you, Mandeep. Good afternoon, all. I think I'd take the opportunity to spend maybe about a minute just setting the foundations for our discussion today, welcoming our esteemed panelists, experts in their domain. I really wanted to talk about how population genomics is leading us into a new forefront and frontier within clinical genomics and clinical therapies. So if you're all aware that the UAE started a population genomic program about 3 years ago, one of the largest population genomic programs with the aim to sequence the entire UAE population. This has a forefront vision to really look at how to translate this data in petabytes worth of data and have an impact on healthcare and the delivery of healthcare. So I think while we set that foundation, my first question is to Dr. Stephen, and it will be around how do we see this whole genome sequencing or genomic data being translated into day-to-day clinical care?
Well, thank you for the question, and I'm happy to be here.
Higher up the mic.
So genomics in oncology is part of almost everything that we do. And we've been involved with the Emirati Genome Project for the last 3 years, and a lot of our focus has been on integrating this population data into what we do every day. And we've already started to do that. We're now very capable of seeing a patient, collecting their genomic information, and then bringing that back to the clinic. And all that's done within our entire own ecosystem. So it makes the process faster, cheaper, and more available for patients. And that's critical for our patients to have the best results that they possibly can.
Thank you, Dr. Stephen. So if I was to take a point from that, is the information that we're receiving through genomic data is impacting life within the healthcare system itself. But maybe a question to Dr. Val. So this genomic data is immense. It's extremely large, right? So how do we translate this to take all the insights, but that have a direct impact on patient care? Because I'm sure there's a lot of data that's available to us, but what do we do to get the best insights out of this data that impacts patient care?
I think that currently clinical genomics makes more and more impact on the health of the population and all this innovation. And you correctly mentioned that Emirati Genome Program, which built a foundation of genome program here at UAE, and I just would like to touch a few points that first of all, we're unique from several perspectives. We have we plan to have over 1 million participants. We also sequence the genome with a clinical grade, which allow us not only to do research, but also allow us to do clinical testing. And it affects us in several levels. It affects us on a personalized level because we can make better diagnosis. We can identify better treatment for the particular patients. It affects the physicians because physicians get the access to genomics data which they can analyze, and they can take a decision in order to prescribe better treatment with a better outcome. And obviously it affects us on national level because we can look at the trends and we can design the program which will tackle these trends. And with all this data in mind, we have special programs which also assist us to analyze this data. And the genomic data go through several layers of interpretation, and the final layer of interpretation is obviously the clinical layer of interpretation, which allow us to assess each patient from the clinical perspective, correlate with the genomic findings, and create the clinical reports which we deliver to the physician.
Thank you, Dr. Val. So I think that's quite important, is the actual analysis of the data is targeted. So while the data set is very large, it's important to understand that when we're looking for an area of interest of pathogenicity, we have to be very targeted in our approach. Otherwise, we won't be able to really have a precise way of diagnosing or treating. So Dr. Fawad, in your capacity as the hereditary high-risk lead at the Cleveland Clinic Abu Dhabi, how have you seen some practical use cases within your clinics of utilizing this data?
Thank you so much. The hereditary high-risk program is probably one of its kind in not only the UAE but the region, where and Cleveland Clinic is very uniquely placed to offer this. We are very fortunate to have our collaboration with the bioinformatics experts there at G42 and M42. And then a multidisciplinary team of experts at Cleveland Clinic Abu Dhabi. What we aim to do is we aim to identify population which is at increased risk of developing hereditary cancers. And traditionally we used to do this by elaborate personal and family history. But now with the help of genomics, we are able to personalize it, to convert it into a personalized prevention precision program. What we do in this program, getting all the genomic information, we are able to identify patients at increased risk. Once identified as increased risk, we are able to put them on a prevention program. The prevention program has 4 key components, just very briefly: enhanced screening, lifestyle modifications, preventive medication, and preventive surgeries. So it's not only picking up cancers early, but also reducing the risk of cancers, the hereditary cancers specifically.
Thank you, Dr. Fawad. There was a few buzzwords Dr. Fawad used there, which is prevention, precision. And maybe I'll take the opportunity to ask Dr. Stephen here on what is actually meant by precision care, precision diagnosis, precision therapy, and how are we using genomic data for this?
Yeah, this is a great question, and medicine continues to evolve. And what we've realized in oncology in the last 10 to 15 years, and even more recently, is that a patient, for instance, with lung cancer is not the same as another patient with lung cancer. Historically, when a patient came with lung cancer, we would treat the patient with lung cancer medication. But now with genomics, we're able to very accurately, genomically, evaluate a tumor. And that evaluation directly impacts the treatment of the patient. This is much different than it was when I was in training a few years ago. And we're doing things much more precisely. What this is leading to is more effective treatments, and treatments with less side effects. Because we no longer shotgun every patient with the same treatment, but we pick a treatment that we know is effective, and we also eliminate treatments that we know are not effective. So this is really what we mean by precision medicine, and it is changing and will continue to change for the long term how we are better able to treat our patients.
So I think maybe it's sort of, in simple terms as I understand it, we used to historically treat the disease or the condition. Now we're treating the individual with that condition or disease, and we're understanding that disease from a molecular genomics perspective and the best therapies that are targeted. And I think that would lead me to my other question as well to Dr. Val here. So this population genomic program, there's been many sort of elements that have been bolted on. One of them is the clinical genomics application and the utilization for diagnostics. But there's another element regarding the pharmacogenomics. Can you maybe describe pharmacogenomics in a simple term to our audience here, and how the genomics, how that impacts the treatment of our patients here in the UAE?
Pharmacogenomics is a type of test in which meant to identify what type of analyzers we are, because we can be intermediate, we can be ultra rapid metabolizers, we can be slow metabolizers, and it affects us significantly because each of us, if we sequence our genome and analyze it, we will be differently utilizing all sorts of drugs we're getting. And this is very important factor because one pill which is prescribed for one patient will not affect this different patient with the same efficiency because, for instance, slow metabolizer, you take the medicament and can accumulate in your blood and become toxic if you're a slow metabolizer. But if you're ultra rapid metabolizer, the same drug will be metabolized quickly and you will not get this same effect which you're supposed to. That is why pharmacogenomics, the main goal of pharmacogenomics is to identify what type of metabolizer you are and what type of treatment you can get. So you will have more efficiency, less side effect, and obviously, in general, optimize your treatment.
So as a follow-up to that, Dr. Stephen, where do you see the health economic impact of utilizing a tool like pharmacogenomics with your clinical practice, and ultimately will it lead to better patient care?
There is no question that it is and will continue to do that. Historically, we would treat all patients the same, and then we'd pick out the one or two patients out of a large group that had a problem, a reaction to a medication, or it turned out they were underdosed and the treatment wasn't very effective. Now with pharmacogenomics, we can predict ahead of time what dose of a medicine a patient needs. And it could be that they need a lower dose than most other patients and still have a high effectiveness. Or it may turn out that they're a rapid metabolizer of a certain drug and they need a higher dose. So this is very important. It's allowing us to eliminate complications from treatment that historically we had because we can predict ahead of time who needs what and how much of what they need. So it's really changing the way we do things.
Thank you. So we've been describing methods within precision medicine, but there's a key element here, right, is the prevention of disease itself, which I think is a very poignant discussion point. So while we're now diagnosing diseases better, we are having better clinical therapeutics because of the genomic makeup of the individual and the subgenomic marking of the disease itself. But ultimately, it's better to prevent the disease from happening in the first place than to treat the disease later on. So Dr. Fawad, from a prevention perspective, using this genomic data, what insights could you pull to really help on reducing the disease burden within our ecosystem here?
Great question. So we know, according to the Western data we have, that in any given population, up to 5% of the population might be carrying cancer genetic mutations. Although we're doing a lot of research in the area to understand more about the Emirati population genetic variant proportion, if we are able to identify this population and be able to put them on prevention programs, we can make a huge impact on reducing the cancer burden, the cost burden, and we are very fortunate to have over 400 high-risk patients on our program since last year. And this program, it promises, as I mentioned earlier, not only early identification, but also risk reduction. So through the genomic information, for instance, if a patient has one of the commonest mutations called BRCA2 mutation, these patients we know are at increased risk of multiple cancers, so breast, ovarian, pancreas, prostate, and if identified early, we are able to put these patients on not only the lifestyle, there's a question, not only the enhanced screening and lifestyle, but we have preventive medication, and the preventive medication data shows can reduce the risk by 60%. And then, and finally, we are fortunate to have the surgical oncologists, likes of Dr. Grobmar and the entire team of not only the breast, but ovarian, colorectal, prostate cancer experts who have expertise in managing these genetic variants and are able to offer risk reduction surgeries. For instance, for BRCA2, risk reduction mastectomies are frequently done. So I hope that gives you a little bit of an idea of how we manage these patients. Thanks.
I just want to emphasize what's really new here, and something that's really been never done on scale in the world. Traditionally, as we care for patients, we would wait for them to develop cancer. Maybe a 35-year-old walks into my office with a new diagnosis of breast cancer. We would then refer that patient for genetic testing, only to find out that they have one of the predisposition genes for breast cancer. Think of the world in a different way, where now we have access to 500,000, 600,000, 700,000 genomes, and instead of waiting for patients to get cancer and then do their genetic testing, what if we did offer the patients genetic testing before they get cancer, and then we refer them to the high-risk program? So the potential is a new way of thinking that is really only possible here. And we firmly believe this is going to change the way we treat and diagnose cancer and prevent cancer in the future. And we're glad to be part of it.
So you actually stole my next question. Thank you for that. But I'll try to position it slightly differently. So I totally agree. If we have the information, and the whole idea about a population screening program is, first of all, potentially to eliminate the disease from happening by, for example, programs like premarital screening. If a couple is aware that their potential offspring could be liable for a hereditary disease, then they're able to take measures to reduce that risk. So that's starting to reduce the risk of disease from very early on. And then so on and so forth. As you work, as a baby is born, you collect a sample and you have a whole genome sequence from the baby's birth, which allows you therefore to Dr. Grabmai's point, to predict the disease and prevent it from happening or manage it very early on. So if we move on to other sort of genomic programs like non-invasive prenatal testing, Dr. Val, what would be your position on how non-invasive prenatal testing as another genomic screening platform has allowed us to reduce the risk of disease and burden?
It's a very interesting question, because initially non-invasive prenatal screening or non-invasive prenatal testing, when firstly it was introduced, it was meant only for high-risk group, for pregnant women. But then gradually it makes its way, and currently in the US it's offered to any pregnant women because of high sensitivity, specificity, and it's actually non-invasive, and you can act on it. And I think that that program paved the way to make sure that you will be able to carry the healthy baby and can help your physician to actually plan it in case if something goes wrong, act on it on time. But again, I want to make sure that you understand it's a screening, it's not a diagnostic testing. In case of certain suspicious of the anomaly, the confirmatory diagnostic testing has to be done.
So I think on that point of screening tests, what is the new sort of age within clinical genomics is what we call the liquid biopsy or the liquid gold. And this is really a new innovative methodology and technique based off the NIPT type of methodology, where we can now start looking at potential cancers within someone's blood sample and not wait for that cancer to come to fruition. So Dr. Grabmai, can you give us a bit more insights on where this technology is moving and how you see this to be used within the clinical applications, both in the screening method or potentially within a diagnostic domain?
So another very exciting area that we're very invested in. The first area revolves in screening for cancer using genomics. And what we've learned over the years is that as a small cancer grows, it may spill little bits of DNA into the blood. And now what's being developed, and in some cases is ready for clinical use, is the ability to capture a small sample of blood and then do DNA sequencing on the blood and find these little fragments of DNA in the blood. And before we could even see something on imaging studies or a patient has symptoms, we now have a signal that this is a patient who may have very early cancer. And in oncology, there's no doubt that the earlier we find a cancer, the better the prognosis and the less treatment a patient needs. So this is going to revolutionize now and in the future the way we screen for certain cancers. The other area which Alvaro pointed out was using it to treat cancer. So it turns out that instead of doing a traditional biopsy, for instance, there's certain areas in the body that are very hard to biopsy. The lung is one of them. So if a patient comes in with a spot in the lung and that we need to biopsy, it may be in a very difficult spot for the radiologist or the pulmonologist to pass a needle to get a sample. Well, it turns out that based on that same concept, we can sample the blood and actually find some of those cancer cells in the blood, and then we can do the genetic sequencing on those cells. And in many cases, we can use that sequence to determine what treatment a patient would need. So this is really changing the way we approach patient care. It's also important because it's easy to repeat a biopsy of the blood. You just draw a blood sample. And we know that some of these tumors change over time, and repeating a biopsy on somebody's lung many times is not really practical, nor would anybody allow them to have that done. So this ability to actually get a window into the behavior of the tumor by using a blood sample is revolutionary, and we're, again, glad to be very part of this revolution.
Thank you, Dr. Grabmaier. While we have experts in our panel who understand the application of genomics, my question, Dr. Fouad, is how do we institutionalize this type of approach within the clinical domain where we don't have the experts in clinical genomics or the SMEs, but to be utilized in day-to-day clinical practices?
I think we need to really go out and create awareness of this change in personalized precision care. And I think we need to collaborate closely with our primary care practices all around the country to create awareness and to be able to do little quick risk estimation to identify who's at increased risk of developing cancer. And I'm speaking specifically of cancer because that's what I manage. And if anyone is identified of increased risk, then to be able to refer them to the hereditary high-risk practice at Cleveland Clinic Abu Dhabi. And we really don't need to do genetic testing at a very small level. If it's a small, one physician, two physician-led primary care practice, even if we are able to identify who's at increased risk by simply taking an elaborate personal and family history, we can really help the population at that level. I think the next step would be then to also integrate them and have them be able to do genetic testing at that level. And again, it's all about creating awareness, sharing the best practices, the criteria for genetic testing. And so we are already working with the other assets of M42. So we hope to continue to create this awareness more and more.
Wonderful. Thank you, Dr. Fahd. Just in the interest of time, I'm going to just finalize with a question before we go to the audience for any questions to all our panel here. So, Dr. Val, if you were to describe very briefly one challenge and one wish that you have for 2024, what would it be?
I would like to have more automation, which will help us. I'm talking about automation, I'm talking about artificial intelligence, which help us to analyze in a better way, in a more efficient way, all this amount of data which we're getting, because regrettably now the bulk of our technical knowledge goes a little bit ahead of actually our scientific knowledge. I would like to be it on pair.
Thank you, Dr. Val. Dr. Fawad?
Well, my wish would be to have the Emirati Genome Program kick off as soon as possible, so we are able to identify the high-risk population and be able to do something about it, then wait and keep them at high risk and end up with cancers.
Thank you. Dr. Stephen?
My wish would be that we initially, very simply, utilize the information that we have. We know from a lot of population studies around the world that genetic testing is currently way underutilized. And if we just, in the next year, accomplish for our UAE, if we just accomplish raising awareness and utilizing the resources we have without any new innovation, we can have a massive impact on the health and healthy living for our patients and their families. So that would be my wish for this upcoming year.
Thank you so much. I'll pass to the audience for any questions for the last couple of minutes before we close.
Thank you so much for this amazing presentation. I'm actually a molecular biologist and a healthcare strategist. And when we come to scientists and healthcare professionals like yours, I mean, you understand that this is a screening and it's not really a diagnostic when it comes to prevention. When we want to communicate to the population and to have the right channel of people to be screened, I'm just wondering what sort of communication would be to invite those. Is there a list for those people with risk factors? I mean, not to scare them, but at the same time to support them and to help them. And because especially with the introduction of AI, you have now the possibility of diagnosing or screening and knowing the population with a higher risk of developing a certain cancer with those gene markers. So, but the common population, not all of them are aware, I mean, that this is not, I mean, if I have this gene, I will be scared. I mean, in the back of my mind, I would think I will have this cancer or I'm predisposed. So I would like your feedback on this. Thank you.
Thank you so much. Clearly you're a molecular biologist and a strategist, because this is exactly the challenge that we face is, are we going to bombard the healthcare ecosystem with this data? And that's a very, very, very important question, because do you go with a very pathogenic disease causing variants, or do you go more with stratification? Dr. Grabmaier, if you don't mind, can you give us a very brief insight into your opinion on this?
There were many great questions there. I think a lot of what we have to do is continue to educate the public. And in my 4.5 years of living in the UAE, we've made a tremendous progress already in educating the public about the power and the risks of genomics. So how we talk to this, how we talk to people about this is very important. As you point out, we need to be culturally sensitive. We have embraced the model of genetic counseling, and we are firm believers in the role of the genetic counselor in educating patients, doing pre-test genetic counseling, and then using the genetic counselors also to do post-test counseling. And we think this is the safest way to implement this. And the last question you raised was about how to identify patients at risk for germline genetic testing. We actually envision a world leveraged through the Emirati Genome Project where all patients, because we also know that we're pretty good at predicting risk, but we're not great, and that we know that many unselected patients unexpectedly will have a germline mutation. And if we can use the Emirati Genome Project to find them, then we can help them and their families. So thank you for the great question.
I think in the interest of time, I believe we've run out, correct? So I apologize if there's anyone would like to ask the panelists any questions, feel free to reach the panelists after the talk. Thank you so much for your time.
Thank you.
Thank you so much, and thank you, Albara, for expertly moderating that panel discussion. I really appreciate that. We're going to take a photograph with you all on stage, and then we're going to dive straight into our next panel discussion.